The views and opinions expressed by the guest speaker on this episode are solely those of the guest. The content shared is intended for informational purposes only and should not be construed as professional advice or endorsement.
Hi, I'm Diana Gonzalez, your host and PhD student in experiential education at the University of New Hampshire. Welcome back for part 2 of our conversation with Dr. Anita R and Dr. Lynn Norton of the Outdoor Research Collaborative for Health, Wellbeing and Experiential Engagement. When we finished up last time, we were discussing the importance of informed consent. I'd like to shift us into the topic of risk management now. So what role does risk management play in adventure therapy, and how do you ensure client safety during activities?
Yeah, I think we have to be able to talk about risk management, Diana. Thank you. And the field traditionally, if you think about the field of outdoor experiential education and moving into a more therapeutic application of those practices, I think has always thought about physical risk management of clients related to being suspended in the air or using a belay system, right? Some of those more high adventure pursuits that some adventure therapists are trained in. However, the field is also shifting to look at psychological risk management. And so knowing then, kind of like Anita earlier was connecting the dots, knowing that psychological risk management and psychological safety is directly related to physical risk management and physical safety. And so organizations like the National Outdoor Leadership School, Outward Bound, the Student Conservation Association, the Association for Experiential Education, those are some of the leaders in the risk management space. And I think all of those organizations would highlight the importance of training and staying in your scope of practice. So maybe for some of the therapists that are listening, they're not trained or ready or prepared to take clients to do a climbing day or a high ropes course day, but maybe they want to do a walk and talk with their clients, or maybe they want to do activities in the office. Even for those, right, there are opportunities for training. And I feel like one of the things that we know is that when we are in our level of competence, we enhance that sense of safety for our clients. They know, right, that they're in good hands, that they're being cared for. And so if you're transforming your practice to an adventure therapy practice, having policies and procedures in place, getting outside consultation, considering whether or not you as a program would like to pursue accreditation as an outdoor behavioral healthcare provider through the Association for Experiential Education, or if you as an individual practitioner want to pursue certification as a certified clinical adventure therapist, all of those things are checks and balances, both for your professional sustainability as a practitioner ethically, as well as client psychological and physical safety. One of the things that I see another trend happening directly related to risk management is really the resurgence of a humanistic risk management framework. And this comes directly out of the work of Dr. Nina Roberts and Sky Gray. And it's being revised and adapted by a group of us right now in the adventure therapy field to really look at how do we, when we consider behavioral risks, interpersonal risks, psychological risks, environmental risks of what we do, how can we bring in those 6 principles of trauma-informed care from the Substance Abuse Mental Health Services Administration of safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment and choice, and then that cultural humility piece of really acknowledging who are our clients? What are they coming to us with in terms of their lived experiences? And are we being respectful and responsive to that as a core principle of risk management, so that people aren't shutting down or feeling othered or immediately feeling an assault or an attack to their sense of felt identity and psychological safety. So this humanistic risk management model is kind of all encompassing of all of those things. And I think it's really going to be where the field is moving to.
So In order to continue to promote well-being and the, acknowledgement of adventure therapy as the truly informed practice that it is, you then have to address some misconceptions. So what are some common misconceptions about adventure therapy or experiential education?
So I'll tell a quick story. So think about, we're just framing it. So this is 25 years ago in 1997 when I started my doctorate at Boston College in social work. And I wanted to do my dissertation on adventure therapy. I had to convince, and not by anyone's fault, but because it was so new, but they're like, how is that therapy? It's play, so this idea that what we do doesn't have therapeutic value. And so again, going back to that intentionality, and we've just spent whatever long amount of time talking about all the things we do intentionally with our clients. So that idea that it's not really therapy, we would challenge and say it is. And we're making astute clinical decisions every single second of our engagement with clients. And it's hard work and it's tiring work. And if you're zoning out, people get hurt. If you're not self-aware and in the moment and really a good observer of what's going on around you, well, all therapists should be that. But this idea that sort of the assessment and the reading of the room and understanding of the environment, that is a skill that is so necessary in this intervention because of the pace and the activity and the engagement, right? So it is therapy, right? And this idea that it's fun. Therapy can't be fun. And we can unpack that around sort of where that's come from, especially with adults. Like we do it with kids, but once we get adult clients and adult participants in with us, that idea that therapy can't be fun. We know that play increases serotonin. We know that play and laughter are regulating. We know all this information around play and laughter and joy. And for people who are isolated and depressed and anxious, bringing in moments of joy and moments of laughter and dopamine hits from joy and excitement are so important. So yes, it is playful. And yes, it's not all fun, but it can be fun. The other thing is that anyone can do it. I like to hike. I hiked the Appalachian. I did the whole Appalachian Mountain Trail. That is amazing, but it doesn't mean that you can bring clients on trail without the right training. I am a really expert whitewater paddler. Please don't bring clients on whitewater without understanding the training of that, right? Being responsible for yourself is a lot different than being responsible for yourself and others, because you have to not only manage your own regulation and engagement and being present in the moment, you have to respond to the clients. So if something happens, like an unexpected, you're out on a small hike and it's a whiteout because you go, all of a sudden you're cold, your clients are cold, you're dealing with hypothermia, but you have to keep yourself and your clients safe. If you don't have the right medical first aid training or understanding of how to do that, you've now put yourself and your participants in danger. So I run a master's program, and I have a lot of students who email me and say, I found your program. It's where I want to be. And then I'll say, okay, but what's your experience? And we ask folks to have 2 years after undergraduate experience where they've developed an understanding of outdoor leadership, those technical skills, in addition to those facilitation skills. So it really is, we talk about dual trained. We are dual trained practitioners in both the technical and safety and understanding of the physical challenges we are asking folks to engage in, and the extra emotional and somatic responses that we need to be prepared for because we use action, right? So it is almost harder therapy. I would argue it is a harder intervention to be prepared for because it asks so much more of us and our own understanding of who we are and how we show up, and that attending to our own environment, our own skills is ongoing and so important, right? So I feel like those are very common. It's play, it can't be fun, it's really not therapy, and if I like to hike, why can't I just bring clients outside?
Yeah, those are important misperceptions to kind of correct. I also think sometimes people think that adventure therapy is like a one-size-fits-all approach. Like, we can use this with everyone. And I would argue that it's really important to assess the individual and whether or not this actually is an appropriate intervention, to be just as thoughtful about some of the, psychological risk factors of adventure therapy and who is contraindicated for this as well. Anita and I are adventure therapy evangelists sometimes, but as licensed mental health professionals who follow our ethical code of practice, we also have to acknowledge that finding a goodness of fit and deciding when this is a contraindicated intervention is just as important of an ethical issue. I also think that, the role of the therapist is a bit different in adventure therapy. And sometimes people will think, oh, it's just like traditional therapy, that's kind of a misperception. And in fact, the adventure therapist, like Anita said, has a greater responsibility, I think, in terms of, monitoring, the client's safety, implementing clinical skills, therapeutic facilitation, monitoring both the person and the environment, actively assessing and intervening and providing support. And so this role requires a lot of really balancing challenge and support, using therapeutic techniques, and also staying regulated and safe yourself, which I know Anita also mentioned. So I think there are a lot of things about adventure therapy. Sometimes it gets, put in the box of like, oh, we're just doing these physical activities and challenges. And people forget it's not just about overcoming physical challenges, right? It's about that therapeutic growth and insight and self-awareness. So I think that, as we continue, as Anita and I are both practitioners and researchers, that's actually our primary role. I feel like as we continue to really build the evidence base and provide that scientific support for adventure therapy and really continue to hone in on best practices as well as who this is for and who this is not for, it can help guide practitioners in this work as well to kind of get past some of those misperceptions.
In addition to all of the other aspects of your professional career, your primary role are researchers. That kind of leads me to ask about the ORC. Can you tell me more about what that is and what you're working on?
Oh, it's so exciting. Well, first of all, finding a title for the research center in and of itself was an experiential practice. How do we find a title that really represents sort of our collaborative dream of sharing power and sharing voice and having, like we would do in an adventure experience as facilitators, facilitating a process where those participants have equal power in choosing direction and aim and goals. And so that's like our goal of the collaborative, is to engage with other practitioners and researchers to come up with a collaborative sense of direction in how we move the field forward in sort of experiential engagement, wellness, and the outdoors. So it's a lot. It's huge shoes to fill. We have lofty aspirations, but the nice thing is we know we're not alone. We have over 40 active collaborators who are joining the center right now, and it's really exciting. So we're really looking to examine sort of key issues in the field that impact outdoor health or are led by outdoor health, advancing practice, really working from a sense of value. So the Outdoor Research Collaborative, the first thing we started was to define as a collective the values that drive our work, and that's where we're at right now. It's been multiple iterations with our collaborative group of humans to define, evolve, look at those so that everyone feels they can align and not buy in, but support. Like that represents, they look at those 7 values and say, yes, that's how I want to be. And that also guides how we work with each other. So the Outdoor Behavioral Healthcare Research Center was a little bit more narrow in its scope and its focus. And I'm really proud of the work we did there. It was revolutionary and bringing together researchers and asking hard questions and building this foundation. Like without the OBH Center, there would be no ORC, but the ORC is very different because we went to a strategic planning where we got information from over 100 practitioners and researchers of what is needed in the field, how would we move the field forward, and it's based on those recommendations and those intentional seeking of input from others outside of our own narrow focus to help us guide in a more global way of meeting the needs of the field. So I am psyched, and I really feel very lucky to have Dr. Norton as my partner in crime, per se.
Just for the listeners, just to give it a little bit more of a linear flow, Anita and I were both research scientists with the Outdoor Behavioral Healthcare Center, which primarily looked at structured mental health interventions in the outdoors. And that center had a handful of research scientists trying to develop an evidence base for the broad umbrella term of outdoor behavioral healthcare, of which adventure therapy falls under. And so one of our commitments, as we honor and acknowledge some of those new trends, those changing trends in our field, is to really broaden our scope. It's to really be more inclusive in terms of the voices and the leadership of what was the center, which is now being called the collaborative for a very intentional reason, as well as building that bigger boat across the continuum of care, again, of health, well-being, and experiential engagement, and not just a structured therapeutic intervention. So just to give the listeners a little bit of scope of the history of that, but I am also delighted to continue that work.
Tell me a little bit about the ongoing research projects or studies that you're involved in.
I can start. There's too many to name, to be honest. And that's exciting. There's so much. We're looking at both prevention, intervention, evaluation, implementation. We worked with Dr. Bobby Veal looking at the implementation of training youth workers to run adventure therapy groups with kids involved in both behavioral health and child welfare, and the impact of that sort of dissemination and implementation statewide in Ohio. We just published something on that, to the evaluation of the impact of Chicago Voyagers out of Chicago on resiliency of those participants in an urban setting, on resiliency and attendance and risk factors in school, to working with collecting information and data of the long-term impact of attending a wilderness program for young adults who attend by choice and have dual diagnosis of both mental health as well as substance abuse and misuse issues. We're also, which we're really excited about, is looking at theoretical frameworks and how do we guide the language around diversity, equity, inclusion work. Diana's part of that, and Dr. Norton and I, and 3 other scholars, of looking at how do we build and implement an anti-oppressive framework in adventure and outdoor programming by looking at what education and social work and the clinical fields are already doing, because there's not as much as we would hope and want and need to guide our work in this particular field. So we're doing all levels of, from sort of conceptualization to implementation to writing, on all those levels of sort of the research platform. And so nothing's off the table, really, for us.
I think also we have always had, myself and Anita, as well as the collaborative, this focus on bridging the gap between practice and research. And so how do we build intentional partnerships with programs and practitioners so we can engage in practice-informed research and then bring that research back to the field to help the field engage in research-informed practice. And so some of the areas that we're looking at, Anita mentioned, we have researchers who are working on issues with veterans. We have researchers who are really looking and honing in at like nature and well-being. We have researchers that are starting to look at prevention programming to try to prevent mental health and suicidal ideation from even occurring in youth and adolescents. We're working on a project with the Wilderness School in the state of Connecticut on really looking at youth voice and youth experience of an outdoor adventure intervention for youth who are system involved with foster care. The list is long, but I guess I would just sum it up to say that, again, our focus is on really building that bigger boat and looking more broadly across that continuum of care, as well as looking at issues like risk management and informed consent and accreditation, and continuing to really prioritize ethical and effective practice to really promote client safety and voice and choice. We take that really seriously.
So for the new folks who are listening or inspired, who now want to join the field, after getting all this information, what advice would you give to someone who's interested in entering the field of adventure therapy, or even trying to incorporate adventure-based methods into their practice?
I think, first of all, they're entering the field in really a lovely time. Looking back on Christine and our 30 years experience in the field, there are organizations and training organizations and places where they can get support. I'm going to talk from my own personal lived narrative. The Therapeutic Adventure Professional Group in the United States, and that's mostly has conferences in the United States, through the Association of Experiential Education, their pre-conference. They have a pre-conference that is the 2 days before the association's larger national conference. So that's in Estes Park in mid-November in 2024. That pre-conference, I always talk to practitioners and I say, if you can afford it and if you can make it there, because, there's always funding issues. If you can show up in person, it would be great. Just show up and we'll introduce you. It's a very warm and inviting environment where showing up, there's enough people who will say, oh, what are you interested in? Let's that connecting, that sort of speed dating, I feel like we do, which we're like, oh, you do veterans. Like the association is doing podcasts and webinars. There's a ton of online support and training online, which also includes CEUs for you to get your feet wet, to sort of see what it's like, what's going on, what's the field about? I have been involved with AEE and TAPD a lot. Through that, there's training organizations. There's Adventure Therapist Inc. Nick Migley-Haberek and Kim Saxterder have created this organization and this training organization to help folks. But they're not the only ones, right? So there is training and all of that for the hope of, there's the CCAT, which is the Certified Clinical Adventure Therapist certificate through the association, which requires certain trainings and certain supervisions. And it's beyond this. There could be a whole podcast on CCAT and that sort of process. But I would invite anyone to go to the Association for Experiential Education and look at the Therapeutic Adventure Professional Group and sort of look through those levels of sort of training and access to ongoing clinical development, in-person things as well as online things. And Christine's got more to add. I mean, there's a lot out there.
I think I would just sum it up to say, find your people. It's been really engaging for me, and really sometimes challenging in a really healthy way to engage with other adventure therapy practitioners. And I've had the privilege of doing that both here in the United States as well as abroad. There's actually a thriving and robust international adventure therapy community as well that also hosts an international adventure therapy conference every 3 years. The next is going to be in the summer, June of 2025 in Taiwan, which is near and dear to my heart. I was a Fulbright scholar there in 2017 and taught adventure therapy at National Taiwan Normal University. So it is like going to be a homecoming for me, but I want to plant the seed for just engagement as well with a diverse community of practitioners, because we only have the lens that we have based on our lived experience, based on our training, based on our worldviews, based on our culture. And as an American practitioner of adventure therapy, it's been really eye-opening and sometimes challenging for me to engage with folks who do it very differently and provide constructive criticism of an American lens or an American model. And so Anita is always fond of quoting Maya Angelou, who says, when you know better, you can do better. And I would say that being in community that really promotes dialogue and critical conversations is a really good way to continue to be an ethical and effective practitioner and a reflective practitioner. So I would say find your people, a community that can both support and challenge you to continue to grow and to be able to provide the best service delivery to our clients, to our participants as possible, as well as just continue to grow and learn as a human. So that's what I would say. Find your people.
And anyone can reach out to either of us. Our email is info@orcollab.org. By mid-November of 2024, orcollab.org will be up and running. But our email is working, info@orcollab.org. We'd be happy to help people connect and to talk more about our own experience. And to piggyback with Christine, it is about being surrounded by community that challenges us to continually and perpetually get better.
Once again, that's info@orcollab.org. And so hit us up with any questions, comments, concerns. And we look forward to hearing from folks. Thank you both. Thank you to Dr. Lynn Norton and Dr. Anita Tucker for being here and joining us on this session.